So, as everyone here is not health professional, I'm just to put down some basic facts. Of course, first of all, colorectal cancer is very, its incidence is very different in different parts of the world, and everyone knows. And the red places, they are mostly with high incidence areas, and it goes together with good living standards. Another point. Almost every killer cancer, every important cancer is stepwise process. Prostatic cancer, breast cancer, gastric cancer, colorectal cancer. So we have time, especially in colorectal cancer, to find the beginning of cancer and to try to treat it. The more big is cancer, which is measured with alphabet T, the more spread it is. Very logical. Most cancers which are coming to us without screening are T4 or T3. 2/3 of them are already locally spread. Less living, more mortality, more money for adjuvant treatment, and not very good results. Chemotherapy is effective. During 20 last years, many new treatments have emerged. Survival has been better all the time, and now about 2 years on average. More chemotherapy possibilities for metastatic patients we have, the more long is the living time for patients. So it's important to have all possibilities, all chemotherapy for our patients to live longer. There is a correlation, linear correlation between the number of drugs available and overall survival. In Estonia, cancer incidence. As in Lithuania, our colorectal cancer is on the 3rd place as incident cancer, almost 800 cases. These are coming from our cancer registry 2008. Now it's 5 years ago. Most likely we now have about 800 cases every year. Our malignant disease in Estonia, as everywhere, most of the patients in the age group 55 to 74. So cancer is a disease of elderly people, mostly. We don't know exactly our survival data, because Estonia took part of the EuroCare study, and the last EuroCare we took part of was EuroCare 3. It's the mid-90s. The best data we have now is UNIS study, which is showing that, I'm sorry, it's in Estonian, but in UNIS study we can show, oh, I'm sorry, this is the incident cases, the first, the incidence cases, UNIS will come. And the new cases, dynamics during last years. We began in the beginning of 2,672, and now the last one 771, and most likely now 800 cases. So it's rising every year, about 5–6%. And here are the, in Estonian, sorry, but all the lines are going up, and we see that the rectal cancer in Estonian Perazole and the colon cancer all are rising every year. Death. The last data we have from the year 2011, we have had 432 colorectal cancer related deaths. So this figure is rising every year too. About distribution or anatomical distribution of colorectal cancer in Estonia. And almost half of patients have the right-sided colorectal cancer, and about half have the left-sided colorectal cancer. And the rectal cancer, about 40% of all. This is quite average if you look around in Europe. Age groups concerning colorectal cancer, and we see that the highest incidence, as it must be, is on the beginning of 70s. Most likely we are leveling off because our people are not living so long. If we would have a better overall survival for people, it would be in the 80s. The spread during the primary tumor reference, the local This is T1, T2 and T3 without regional nodes is 42%. Our regional node, or T3, the third stage is about 18%. So I was quite wondering, in Lithuania you have nice figures about nodal spread. We have many problems with our pathology. Most likely we should have more first stage with nodal spread, but the last data are like this. T4, 6%, and distant metastasis about 1/3. This is a exact sign about our situation. We don't have a screening program. Why nodes are so important? We see the survival depends on the number of nodes examined. This is a well-known fact. And this is our survival figures. It's EuroCare 3, and we see this is in Estonia, but this is a European average, which was then about 50%. So 1 in every 2 patients survived more than 5 years. In Estonia, in this time, we were a little bit above 30%, 35 or 36%. We looked for relative incidence with Finland, and we see that the incidence rates, I mean the age standardized and crude incidence rates are about the same. And in Finland, the survival figures were almost 1.5 times better than in Estonia. So it is about money and about the system. And this is a unique study I mentioned before, and if we look at the colorectal cancer in Estonia, it should be around 50 now by the unique study. It's not so good as the European average, but still a little bit better. We have National Cancer Plan and Cancer Strategy introduced in 2007. We have 2 regional hospitals. The one is my home hospital, the North Estonia Medical Center, and the other one is University Clinic in Tartu. And to some extent, without radiotherapy, oncological service is provided in 2 central hospitals in Tallinn, in our capital, and emergency service is provided in county hospitals too, but no non-emergency oncology. Endoscopy service. In general, our instrumental part is not so bad. It used to be some 15 years ago. We are quite content with it now. We have problems with staff, and we have problems with distribution of endoscopy service. It's centralized in two regional places, but not in counties so well available. And we have some problems concerning the future screening too, about assessment and auditing of endoscopic quality. This is a number of colonoscopies performed during the last 4 years, and here we see we are doing every year about 14,000 colonoscopies and about 2,000 rectoscopies and anoscopies. And this is a distribution of endoscopy service, and we see that the most hot area is our capital area and university clinic area, but there are some places, island Hiiumaa, for example, and in the central part of Estonia, but our distances are only 250 kilometers, not so big, but still the distribution of availability of endoscopy and facilities is quite big, and so we are concerned. Just, thinking about future screening, we are concerned about the endoscopic distribution. Radiology, well developed, no problems with instrumentarium. We have computer tomographies in every county hospitals, in big hospitals, a lot of them. We have 2 stationary PETs and 1 mobile PET machine. Waiting list with computer and MRI is, I think, normal if you are talking with colleagues from other parts of Europe. And the main problem is workload and availability of radiology staff. So we are waiting very often not for the investigation to be performed, but for the radiologist work. Pathology, this is a problem. Full-size labs we have in 3 hospitals, smaller ones in 3 more hospitals. little hospitals don't have pathology service. They are sending their specimens to the big centers, and problems with staff. A lot of our staff is over 65 years, so not so much young persons, overburdened, and lack of vision, most likely connected to the overburdened everyday work. Some words about contemporary colorectal cancer treatment paradigm. Surgery, to some extent, radiotherapy are curative modalities. If we are talking about adjuvant chemotherapy, which is in some sense curative too, then more. Neoadjuvant chemotherapy prolongs disease-free survival in hepatic metastasis. Adjuvant chemotherapy improves survival after surgery, after radical surgery. Palliative chemotherapy improves survival. Neoadjuvant and adjuvant radiotherapy in rectal cancer improves local control and overall survival about 4 or 5%, not so much, but still. And fecal occult blood test and sigmoidoscopy are two modalities of screening which are randomized controlled. Big trials and randomized. The immunochemical method can be extrapolated from web-based tests, but not so much tested on a randomized scale. Surgical treatment. In Estonia, oncology surgery is done in 3 hospitals. We are working on centralization. Emergency cases in county hospitals too. We are performing about 620 colonic resections every year and about 100 laparoscopic resections. Radiotherapy. We have 4 linear accelerators, 3 in my institution, 1 in Tartu University. We are planning to introduce 2 more, hopefully in 2 or 3 nearest years. And neoadjuvant radiotherapy is a standard concerning rectal cancer, and we are using both short and long course, most likely about 50-50%. Possibilities of systemic treatment. We have 100% coverage of capecitabine, no big problems with the use of oxaliplatin and irinotecan. In general, we have a little bit different system for governmental money, but in general, about 25% of cases can be treated with bevacizumab. EGFR directed therapy, we have permission to use it in case of unresectable hepatic metastasis, and it's considered to be 20 or 30 patients per year, but not in a second, first and third line of palliative treatment. And regorafenib, new drug, of course, not available. Chemotherapy done in 3 centers, and the numbers, 2011, 736 patients were treated with chemotherapy, colorectal cancer patients, and about the same 2012. Cost. This is a problem, and I think in general this problem will increase in the future. I mean, without screening and rising incidence, most of people are coming with T3, T4 or metastasized cases, more need for adjuvant, more need for palliative treatments, new therapies and evidence-based therapies are coming, new money needed from government, crisis going on, bad situation. And the cost, this is in Estonia. I made some computing. For example, 4 lines of treatment, I mean, first line, second line, third line, okay, 4th line, the cost 65,000 euros. About screening, this is a table from the United States. We see they are using more and more endoscopy screening, which is rising. Sigmoidoscopy decreasing, which is interesting because we don't have up to now no colonoscopy screening randomized trials. We have at least 3 or 4 randomized trials concerning sigmoidoscopy. But in the United States, more and more colonoscopy, less sigmoidoscopy, and less fecal occult blood test. This is a reason for endoscopic screening. We see stepwise progression from benign adenoma to carcinoma. This is some data from Polish study, and we see that on a national level, of course this was not population-based screening, but still on national level you can achieve quite nice results with endoscopy screening. Cecum breach more than 90%, cancer about 1%. These are the randomized basis of QUARK-based fecal occult blood test. We see 4 big trials, and everyone is showing survival benefit and less mortality because of colorectal cancer. Estonian situation, we see only this little fraction of people are coming with adenocarcinoma within polyp. It shows we have no screening, and it is just incidental finding. It should be far more in case of screening program. Future screening pilot main questions. We are planning screening now. We have made some meetings, and we are planning to introduce our pilot study maybe, if all goes well, next year. Most likely we will go on with immunological methods still, and then we'll see. And our future plan, of course, is to go on to the population-based screening. And I think that as a summary, the most important point, of course, in treatment of colorectal cancer in Estonia, I think, this is balanced approach. We can't put unlimited money only within palliative treatment. I think we must treat every aspect of the colorectal cancer treatment nicely, and this is one of the good things I see in Lithuania and in Latvia. You have begun your own screening programs, which is very good, and I think this is the best way to go on and save more lives. Thank you.